Hello and welcome back for another webinar sponsored by the Women's Heart Health Initiative at the Cardiovascular Research Foundation. My name is Dr. Nisha Jalani. I'm a Columbia cardiologist and assistant professor of medicine there, and also the director of the Women's Heart Health Initiative at the Cardiovascular Research Foundation. We've been so thrilled to be able to share so many of these webinar programs, even during the pandemic, and hopefully, we've gotten great responses on how much this has helped all of you. And we're hoping that we have another exciting topic to talk about. Our seminar today is on healthy weight, healthy heart, and the link between weight, heart disease, and diabetes. And I'm thrilled to be here with two of my former colleagues, Dr. Rekha Kumar, who's an endocrinologist at Weill Cornell Medicine, and Dr. Houman Yagubzadeh, who's a cardiologist at Weill Cornell Medicine as well. So I'm going to kind of kick it off with an introduction. Why is this important? How does weight and heart disease tie into each other? And then we're going to give you some advice in terms of obesity medications, who to see, when is it necessary to see a bariatric surgeon or any of these specialists. And Dr. Yagubzadeh is going to close it off for us by talking about proactive tips, heart healthy diets and things that are proven to show a weight loss benefit. So we're very excited for all of our speakers. And I'm just going to share my screen now and get us started with our introduction. So your weight and your heart. So let's start with just definitions of how we classify weight in a medical perspective. So we use something called the body mass index, which is a BMI, and that's defined as weight in kilograms divided by your height in meters squared. So BMI cutoffs, once you do that calculation, BMI cutoffs, anything less than 18.5 is underweight. Anything between 18.5 to 25 is the ideal weight range. Then this is for adults who are over the age of 20, so we don't use it in children. If your BMI is 25 to 30, it falls into the overweight category. And if the BMI is greater than 30, it falls within obesity, a clinical diagnosis of obesity, and greater than 40 is actually severe obesity. And so these are just some scary facts, but unfortunately it's the truth that obesity is absolutely an epidemic within the United States, and the prevalence of obesity is growing at a very alarming rate. If you look at data from 1999 to 2000 compared to data from 2017 to 2020, US obesity prevalence increased from 30.5% to now almost 42%. And during that same time, severe obesity increased from 4.7% to 9.2%, so almost doubled. Obesity is also more prevalent in Black and Hispanic communities, and that's where a lot of our focus should go, is in preventing, not only preventing, but treating obesity and all of the cardiovascular risk factors that go along with it in these communities. And that's, it's a mix of genetics, family history, but also socioeconomic factors. So if we think about it, I mean, let's be serious, it's much easier and much cheaper to go and get fast food than it is to get like a $17 salad in New York City for lunch. And so these are some of the things that are definitely at play. Healthy food, whole foods are much more costly. So this is just a graph showing, this is back in 2011. So I want you to see this is self-reported obesity amongst US adults. And if you look at the map, there's a lot of green and yellow, right? If we fast forward 10 years to 2021, you can see that the green and yellow is almost non-existent now, and there's much higher rates sort of across the map. So if we're saying, like I mentioned, 42% of Americans are obese, there's also 30.7% that are overweight. And that means that overall, 2/3 of the United States adults are at an unhealthy weight. Ages 40 to 59 are more likely to develop or have obesity. And we know that, but we also know that the rates of childhood obesity is also an epidemic in this country. And at this point is almost reaching or affecting 20% of children. And then let's break it down by women and men. So again, we always call this the Women's Heart Health Initiative, but we always like to talk about facts that affect everybody. So let's give a little bit of breakdown between women and men. Only 33% of women are normal or below their target BMI. 30% are overweight and 37% are obese. And if you look at men, even less are at a target weight or below. So 25% are normal or below, 40% are actually overweight, and 35% are obese. And why is this such a big issue? Why is this something that's plaguing our country, and why is it so important to talk about? Well, it's a multi-system disease. It affects almost every part of your body. So from a pulmonary or a lung perspective, patients with obesity are more likely to have obstructive sleep apnea or hypoventilation syndrome. They're also more likely to develop non-alcoholic fatty liver disease or just fatty liver in general, which can lead to increased risk of cirrhosis, gallbladder disease, pancreatitis. More likely to develop infertility, abnormal menses, polycystic ovarian syndrome, arthritis, just because of the sheer weight that you're putting on your joints, skin problems, gout, venous stasis disease, which means in the legs, just like venous insufficiency, several forms of cancer, hypertension, stroke, cataracts. And then what I specifically want to focus on is the risk of coronary artery disease. And why does that happen? It's because obesity is not by itself a risk factor for heart disease, but it does increase significantly the risk of developing diabetes, dyslipidemia, which means abnormal blood cholesterol, and high blood pressure. So let's dive into that a little bit more. Like I just mentioned, being obese or having an unhealthy weight raises the LDL cholesterol, which is the bad cholesterol, think L for lousy, and the triglyceride levels, which is literally like the fat in your bloodstream. And it also lowers the good cholesterol, which is responsible for clearing some of that bad cholesterol. So the HDL, the healthy cholesterol, is also lower in patients who have obesity. It raises blood pressure, like I said, and there's a much higher risk of developing type 2 diabetes. And I'm going to show you a couple slides on this right now. So if we look at these trends, and this is old data, but I think it's very significant in terms of just looking at the progression. But if you look from the 90s to 2010, the rates of obesity, which are in this top row, significantly increased across the country in that 14-year time span. So you can see there's much more red, and it coincides directly with an increase in the rates of diabetes, which is also staggeringly very red in 2010, with more than 9% of patients being diabetic in those states. So diabetes and heart disease, let's talk about the link there. Heart disease is still the #1 killer of both men and women in the United States. It affects people with diabetes, like coronary disease, heart disease, affects people with diabetes at a younger age, and that includes women. So we're seeing a lot of heart disease rates rise in young women, and that's because diabetes sort of independently negate some of the protective effects of the hormones that we have before menopause. The longer that someone has diabetes, the higher the chances that they will develop heart disease. Diabetics have a 2 to 4-fold increase in the risk of coronary artery disease or peripheral disease, which is also really prevalent amongst diabetic patients. And diabetes is a coronary risk equivalent to known CAD. So what that means is that somebody who has diabetes is at as much risk of a future heart event as somebody who's already had coronary disease. So that shows you how strong of a risk factor it is. And this is now true for about half of women and 2/3 of men. Diabetics are more likely to have multivessel coronary artery disease because atherosclerosis or plaque in the arteries is a systemic problem. And so diabetic patients are much more likely to have problems in several different vessels. And so if you have plaque in the heart, you most likely have plaque in the carotid arteries, in your legs, in the brain. So it's definitely a systemic issue. And diabetic patients have a worse prognosis after having had a heart attack. So what can we do to minimize some of these future cardiovascular risk? So there are things that you cannot change about yourself, non-modifiable risk factors. So age, the sex you were born into, family history, which is defined as males in any first-degree relative who's had a heart attack, less than 55 years old, or any female relative, first-degree relative, who's had a heart attack less than 65 years old counts as a positive family history. Race, and that's a lot, like I said, with the same genetic predispositions. Autoimmune conditions, we know predispose patients to having a higher risk of cardiovascular disease in the future. And then also specifically to women, prior history of preeclampsia. And this is something that this is definitely something that we can grab more patients that are at risk by just working with our OBGYN colleagues. So if you have personally a history of preeclampsia, you should talk to your primary care doctor and talk about future cardiovascular risk. And then modifiable risk factors. So we know that obesity, I mentioned, kind of affects the first three, right? So the top three modifiable risk factors for cardiovascular risk are hypertension, high cholesterol, and diabetes. And that's something that getting your weight under control can also mitigate these risks. Smoking is the #1 killer worldwide. So obviously that's something that is definitely modifiable and advised to stop yesterday. And then diet and exercise, we'll talk about more. Like I said, Dr. Yagubzadeh is going to give us a whole lecture on diet, but even physical inactivity. So we know that exercise, even light exercise, anything that gets your heart rate up for 30 minutes out of the day, most days of the week, can improve cardiovascular outcomes by, increasing the healthy cholesterol, lowering blood pressure, causing weight loss. And then other things that people don't think about as much, but we know that poor sleep and then mental health conditions like stress and depression are also risk factors for cardiovascular disease. But these are all things that can be worked on with your doctor. And why is it important to get your weight under control? Well, we know that all of these complications, all of these systemic complications of obesity can be reduced with a significant percentage of weight loss. So even at 0 to 5% weight loss from your current weight, there are beneficial effects towards the blood pressure and also towards the blood sugar, so preventing diabetes in the future. A 5 to 10% reduction in weight can prevent fatty liver disease, high, cholesterol problems, PCOS, and also prevent diabetes if you haven't already developed it. A weight loss of 10 to 15% can start to reduce the cardiovascular risk. And that's what's really important is now obesity medicine, diabetes are all focusing on future cardiovascular risk because we know that that's the #1 killer of all people in the US. And then at greater than 15% weight loss, you actually start to see remission in type 2 diabetes. So what that means is that you could essentially cure diabetes. You have a reduction in cardiovascular mortality and also a reduction in future heart failure development. Let's leave you with some positive tips. So like I said, exercise is really important. It can reduce weight and future cardiovascular risk, and that's been proven. Eating healthy, and this is what Dr. Yagubzadeh is going to talk to us about, but prioritizing fruits, vegetables, whole grains, healthy poultry, and fish. It's kind of stuff that people already know. So you're supposed to stay away from fried foods and saturated fats and, red meat and all that stuff. People know this, but it's much harder to implement unless you make a conscious decision to do so. And then most importantly, speak with your primary care provider about any weight-related concerns and create a very individualized plan that has very realistic goals for yourself. And so losing 15% of your body weight within 6 months is fantastic, but it's not sustainable unless it's something that's really going to be slow and steady and something that you continue throughout your life. It has to be a lifestyle change or else it won't work. And then most importantly, seek an evaluation with your endocrinologist, especially if you already have type 2 diabetes. And there are endocrinologists who specialize in obesity medicine. But this segues very nicely into our first speaker, Dr. Rekha Kumar, who is an associate professor of clinical medicine and an attending endocrinologist at Weill Cornell Medicine. She specializes in the diagnosis and treatment of various endocrine disorders, including obesity, weight management, type 2 diabetes, polycystic ovarian syndrome, thyroid disorders, and metabolic bone disease. She also, very impressively, is the former medical director of the Board of Obesity Medicine. And so I'm going to hand it off to Dr. Kumar to take us through some of the medical therapies that are indicated for obesity medicine.
Awesome. Thank you for the introduction. I'm going to talk about some recent updates and advances in the field of obesity medicine. Some of it you just heard from Dr. Jilani, some of it might be new to you. So other hats I wear, I'm the chief medical officer of a digital health company called Found that focuses on obesity medicine. So we just talked a bit about the scope of the problem. I also would like to talk about the cost of the problem. So as Dr. Jelani mentioned, there's been an increase in the prevalence of obesity in men and women in the United States, but really across developed and the developing world. In the United States in 1960, 10% of men and 15% of women had obesity. And now we are basically at 40% of men and women. So we really saw this rise begin in the late 1970s, early 1980s. And then the diabetes epidemic sort of trailed the obesity epidemic by 10 years. So you can really see that correlation there. In addition to the increased prevalence, obesity is costing the United States healthcare system a tremendous amount. The estimated annual cost of obesity is $147 billion, and a patient or person with obesity has $1,500 per year of higher healthcare costs than those that are normal weight. Patients with obesity spend 42% more on direct healthcare costs. I keep going here. So we talked about defining and measuring obesity. Dr. Jelani talked about body mass index. I really want to emphasize the limitations of body mass index as well. Although it is what we use when we look at populations of people, it is a pretty crude measurement that doesn't really tell us. It tells us how big or how much mass someone has. It doesn't necessarily tell us how unhealthy or how much unhealthy fat someone has. So the true definition of obesity is an excess of fat that impairs health. And BMI is basically the easiest, cheapest way we can assess this number on a population scale. But there are people with higher BMIs that may be healthy, and there are people with lower BMIs that can develop metabolic disease. Sometimes this may be different in different ethnic groups. There are certain ethnic groups, Asians, South Asians, that may start developing metabolic disease at body mass indices that may look normal. There have been discussions about changing BMI cutoffs for different ethnic groups to really correlate it with metabolic risk. So we do define obesity as an excess of fat that impairs health. More accurate ways to measure it are things like a DEXA scan or bioimpedance analysis, but these are not practical tools that we have in doctors' offices, which is why we use body mass index. So how does obesity actually cause disease? Dr. Jelani showed a nice slide about all of the diseases that obesity may cause, but how does it actually do that? In the middle here, I have what is a fat cell. We, for decades and decades in science and medicine, thought the fat cell was just a depot for fat. We did not know it was metabolically or hormonally active. What we've learned since the mid-90s is the fat cell is actually a very active endocrine gland that releases many mediators of disease, which means that there are chemicals and hormones and inflammatory markers released by the fat cell that can predispose to certain diseases. Examples include markers of inflammation like interleukin-6, leptin, TNF-alpha. These are specific medical terms that are related to diseases like arthritis, cancer, atherosclerotic cardiovascular disease. Fat cells also increase the amount of estrogen that's floating around. Estrogen is associated with certain cancers of the breast, of the uterus. Increased estrogen also increases your risk of blood clot. The fat cell can increase levels of a hormone called angiotensinogen, which increases the risk of high blood pressure, and many others on this slide to give you a sense of how the fat cell actually leads to disease. Something I want to highlight is the relationship between COVID-19 and obesity. And this has been a really, big deal in the past 3 years when we learned early on in the epidemic, when we were trying to learn who is getting sick, who is getting hospitalized. And in the very early days, we noticed that people with certain comorbidities, such as cardiovascular disease, diabetes, kidney disease, were all at increased risk of hospitalization, mechanical ventilation, and ICU admission, and even death during the COVID pandemic. And what we learned was a lot of things that make people sick from COVID actually are similar things that people with obesity experience. Those things are increased inflammation, impaired lung capacity, And so this combination of obesity and COVID led to extra severe disease, which is really what led to some of the early indications of a vaccine. I know some people felt that it was stigmatizing and offensive when the initial people that qualified for the vaccine were people with a BMI of over 30. And for the first time, some people realized, oh my gosh, I'm being classified as having obesity. Now I can get the vaccine. People were happy to get it, but they weren't happy to get this new diagnosis. And so although there is this association, we really don't want to use this information to further stigmatize a population with obesity, but rather to encourage people to get treatment. So this is complex. I won't go into it in detail, but the point of this slide is to show people that we're not fully in control of our body weight. And that sounds crazy after years of the diet industry telling us, eat less, exercise more, you can control your weight. What this shows you here in the middle of the slide, it's actually a cartoon of the brain. And in the middle there, that blue ball on the slide is actually the appetite regulating center of the brain. So your brain has some set point weight that it thinks is normal. That set point weight, it's based on your genetics, your age, your menopausal status, medications you're taking, hormones. It's very complex. Set point can change, but there is a set point weight your brain is trying to control. And the way it receives signals to control that set point is what we call from the periphery, meaning the rest of the body. And that's what you see on the bottom of this slide. You see the stomach, you see the liver, you see the pancreas, you see the fat cell, and there's signals coming in from all parts of our body that should be telling the fullness center of our brain, you are full, this person is full, they're fed, reduce appetite, stimulate weight loss. Over time in patients with obesity and diabetes, these signals may not work right. They may not work right in just people as we get older. We all do tend to gain weight over time. It is a normal adaptation to life and to survival. But when we start out gaining weight in our childhood, in our teens, starting developing insulin resistance and prediabetes in our 20s and 30s, we're a setup for type 2 diabetes, obesity, and cardiovascular disease by our 50s. And so although some amount of weight gain and fat gain may be normal and healthy, we're seeing an exaggeration of that. And we have some control, but we don't have complete control because the brain is really deciding at some point, what weights will I accept? And that's why dieting is so hard, because your brain can fight back and your body can fight back. So this is related to that topic. Why don't people just lose weight? So when we gain weight, why can't we just go on a diet, lose the weight, and keep it off? So this is meant to show you after weight loss, whether it's through diet, through exercise, through surgery, a bunch of hormone levels change. After weight loss, the levels of fullness and hunger hormones change in a direction that favors weight regain. So these hormones that I'm showing is arrow down, leptin, insulin, your resting metabolic rate, PYY, GLP-1, CCK. These are all weight regulating hormones that after you lose weight, their levels drop. And those are fullness signals. So your fullness signals are down. And then you have ghrelin, which is a hunger hormone. The arrow is pointing up, and your hunger. So basically what happens in the weight reduced state is all of the factors are favoring weight regain. And that's what your body does in response to weight loss. So how do we actually treat patients once they've developed obesity? This is what we call the obesity treatment pyramid. At the base is behavioral intervention. Everybody, whether they're normal weight, overweight, or have obesity, should be practicing behavioral intervention to either maintain their weight or prevent weight gain. And that includes some version of a calorie-reduced diet and increased physical activity. For people that need the next level of intervention, they can't control their weight with lifestyle, we could add FDA-approved weight loss medicine. And for people that medicine isn't sufficient, there are people with a body mass index of over 40 or over 35 with a weight-related medical complication that qualify for weight loss surgery. So everyone's talking about weight loss medicines. It's all over the media. I just want to give a quick historical view of how anti-obesity medicines, or AOMs, in the United States have been viewed. Generally, they don't have an impressive history in the United States. Some of the older medicines, Fen-Phen, Rimonabant, Meridia, Belviq, these are all relatively recent, past 10, 15, 20 years, were all taken off the market due to side effects. When we see something like this, it really not only makes healthcare providers, patients, but regulatory agencies, very nervous about the idea of weight loss medicine because it hasn't gone great before. More recently, we actually have had safer medicines that have been effective and rigorously tested, such as Qsymia, Contrave, and Saxenda. So they were more aggressively tested, safety profiles, efficacy data, post-marketing studies were carefully monitored, but these medicines showed modest weight loss, meaning 5 to 10% loss of total body weight. That's a very small amount of weight relative to how much the average American with obesity needs to lose. So these medicines, such as Qsymia, Contrave, and Saxenda, were generally underutilized because people didn't really know if the benefit outweighed the risk. So in comes the miracle drugs, all over the Wall Street Journal, all over the New York Post, all over everywhere recently. The newer class of medicines are called GLP-1 receptor agonists. You might know them as the names of Mounjaro, Ozempic, Wegovy. They're in a class of medicines called GLP-1 agonists. If you remember a few slides prior, I told you the hormone GLP-1, a fullness hormone, goes down when you lose weight and you feel hungry. This is replacing that hormone to increase your fullness as you diet. So the point of these medicines is to be used as an adjunct to nutrition and exercise to help people lose weight and keep it off. The newer medicines, such as Ozempic and Wegovy, you can see weight loss ranging from 12 to almost 25% loss of body weight in certain patients. On average, I'd say 15 to 20%. And these are agonists of that hormone I mentioned, GLP-1. Some of the newer medicines are called dual agonists. They actually mimic two fullness hormones to make someone feel more full, regulate blood sugar, stimulate weight loss, and prevent weight regain. So now that we have these effective medicines, how do we actually expand care to patients? So there are a lot of limitations and a lot of things that people in my field are fighting against. One is legacy weight care programs focused on eat less, exercise more. That has always been what the commercial diet industry has told us. It's often what doctors have told patients. And we should all be monitoring our caloric intake and exercising. But for patients that are prone to developing obesity, this has really not worked. And patients that have been told this can, feel stigmatized and nervous to seek out obesity care. So another limitation is that only 1% of doctors are trained in obesity, and most primary care providers are really overstretched. So it's really a challenge for primary care providers to add this to their plate. So then what about academic centers that have weight management centers? I would say that those places actually treat obesity right. And they do give sophisticated obesity care that's individualized, but it's been practically impossible to scale. These places have 6-month wait lists. The patients are very complicated. And even these centers often can't provide the combination of behavior change, psychological support, medication, comorbidity management. It's such a multidisciplinary field. So that's where telemedicine comes in. Over the pandemic, many fields of medicine went on to telemedicine briefly. A lot of doctors that were in their offices saw patient volume drop. There were a few fields of medicine where there was actually an uptick in volume, meaning that more patients were seeing their doctors over telemedicine, and endocrinology and obesity were two of those fields. And the reason for that was really the frictionless experience, the fact that there's like a layer between the doctor and the patient removes some of the stigma. Although we all should be examining our patients and we want to give them physical exams, the frequency of visits required in endocrinology, diabetes, and obesity lends itself well to telemedicine care. Previously, patients that saw doctors for diabetes and weight care tended to have a lot of no-shows. They wouldn't come in if they gained weight. They were embarrassed if their blood sugar wasn't under control. And we actually saw that patients over telemedicine did come to visits more frequently. In light of that, a lot of digital health companies have emerged that really try to use technology to deliver behavior change plus medical therapy as a way to scale the practice of obesity medicine. It seems to be an effective tool when someone's PCP is always looped in. Some of them are subscription models, some are direct to consumer. They're very interesting. So new challenges we face as obesity rates continue to climb. So one of the limitations of these miracle drugs is the cost. I would say that that is the primary limitation. They're extremely expensive. A class of medicines that 70% of the US population qualifies for cannot cost, $1,500 a month. We would bankrupt every employer. Telehealth regulations are changing very quickly. So even the successful telehealth companies have to really, jump over hurdles to know what they can and can't do on a daily basis. And what is the role of behavior change in the setting of these miracle drugs? And everyone says this, do diet and exercise still matter? Of course they matter. They are the fundamental base of that pyramid I showed you of the behavior change or the obesity treatment pyramid. And the intensity of lifestyle change required to prevent disease is modest, while the intensity of behavior change to treat the disease is high. So an ounce of prevention is worth a pound of cure. I really do believe that this is a disease that we need to emphasize prevention in pediatrics and childhood and really continue to do that through life. So those are the updates in my field, and I'm looking forward to hearing from my colleague about the updates in nutrition and cardiology.
Thank you so much, Dr. Kumar. So a couple questions come to mind because this is such a hot topic, like you said, in social media and like in public in general. But as somebody who's not a specialist in obesity medicine, if you're a primary care doctor, if you're a cardiologist, how is it, we know that we can get drugs like the miracle drugs, right? We can get Ozempic, we can get Mounjaro for diabetic patients. How easy have you seen, how easy can it be for other providers to be able to prescribe these drugs more for a weight loss indication?
So I think it's very challenging. I think that there's only two that are FDA approved for chronic weight management, which are Wegovy and Saxenda. Coverage is not good. They're probably covered 30% of the time by commercial insurance, and they're not covered by Medicare. And then in terms of off-label prescribing, meaning prescribing diabetes medicines that work the same way for weight loss, there's tremendous crackdown on that in terms of from pharmacies and insurers because of the inappropriate prescribing. There are a lot of people that should not be on these medicines that have gotten a hold of these through Medi-Spas and other places. And so I would say it is a challenge. I think primary care doctors are trying to write more of these prescriptions, but when they face this kind of pushback and the administrative burden it leads to, it discourages people from prescribing. So I would say it continues to be a pretty big challenge.
And I think that, correct me if I'm wrong, but wasn't there like a shortage of a lot of these medicines for patients who were diabetic and actually needed the medication and couldn't get them filled at the pharmacy because they were low stock?
Yeah, I think generally demand for these meds has been higher than expected, but there also, I believe, were manufacturing delays related to the pandemic. So both of those things caused an issue.
Okay, and then last question would be, when is it appropriate? So let's say that they see an endocrinologist or they see whoever, and they're taking medications and it's still not enough. Like, who is the appropriate patient to refer to a bariatric surgeon?
I would say if somebody has really tried diet and exercise, they've even perhaps tried medicine, and their body mass index is 40 or greater or 35 or greater with medical problems related to their weight, it's appropriate to refer to bariatrics.
Is it ever appropriate to go straight to bariatric surgery without having tried some of these new medications? Because it's a similar sort of percentage weight loss that you're seeing.
Yeah, I think there probably are scenarios of severe obesity. So maybe BMIs over 50, over 60 with type 2 diabetes that and if they're young, putting them on lifelong medicine that won't get them to their goal. I think that there are scenarios that you can and should go right to surgery.
That's very helpful. I learned so much from this because I feel like when we talk about diabetes and obesity and the link and all of that as cardiologists, we miss so much of the endocrinologist perspective. So this was so useful even to me. So thank you so much. And now to really leave it on an empowering note, we want to introduce our final speaker, Dr. Human Yagubzadeh, who also is a cardiologist, who I was very lucky to have train me when I was in my fellowship at Cornell. But he's an attending cardiologist at Weill Cornell Medicine, and he's going to talk to us about some dietary advice and what we can do at home.
Thank you so much for having me and being here. So that was a wonderful talk, Dr. Kumar, and these medications that she was talking about have made a huge difference in my practice as well. And I use both medications, lots of hand holding and talking, as well as a lot of dietary and exercise intervention. And so we're going to talk about all of those things that will be very empowering to folks here that are listening that attempt to try these things. And so the first thing is that we're bombarded by, this was on my drive home about a week ago as I was preparing the talk and thinking out loud as to what I'm going to say. This was on a billboard. And so we're constantly bombarded by this idea that these processed simple carbohydrate foods are part of what makes America great. And it's very, very difficult to go against that. So this shows back from the 1880s to the 2009 time, more than 90% of our diet historically we've eaten at home, home cooked meals, whole foods. And now less than 50% is at home. Significant portion is fast food in red, and significant portion is processed food in blue. Obviously, portion sizes have become much, much larger. And very, very importantly, this shows the amount of sugar in our diets. From the 1700s to the 2000s, sugar is a commodity that's been traded and can be tracked over the centuries. And the amount of sugar per person per year in the in Western countries, this is from the United States, but it's very similar in other places, has gone from less than 5 kilograms per person per year to greater than 50 kilograms per person per year. And that's the long dotted line from the 1700s. You see the obesity epidemic that starts in the 1900s take off when the curve for sugar takes off in the 1950s, truly. And so the link between added sugar, simple carbohydrates, and obesity and inflammation and a whole bunch of the other pathways that Dr. Kumar was talking about is extraordinarily tight. There are many other things that we've increased eating. Cheese and dairy has gone up dramatically. The amount of chicken consumption has gone up. The amount of meat consumption would be in a similar curve as this. And I'll talk about the significance of this in a minute. When we talk about diet, there's lots of controversy in the field of diets. Many folks push one diet, and then you listen to other experts and they're pushing another diet. So I wanted to try to give an overview and marry these things to figure out what the right diet is for you. The same diet is not the right diet for every single person, and diet is very individual. And there are many things that go into diet, meaning what we eat brings us joy. It's a social construct, and it's very important to find something individualized that is sustainable and you can do for the long term. What there is no controversy about ever is that things that are bad in the diet and that need to be either reduced or eliminated are sugar and simple carbohydrates. Saturated fat needs to be reduced, does not need to be eliminated. Processed foods as much as possible, and salt. So those things there's no controversy. What also there's no controversy about is what is good in diet and what we should try to maximize in our diet. Fiber, no controversy. Mono and polyunsaturated fats, no controversy. Omega-3 fatty acids, almost no controversy, minimal controversy, unless you talk to very, very strict vegans. Antioxidants that are found in whole foods, no controversy. And also lots of cancer nutrients that are found in whole foods, specifically cruciferous vegetables, and as well as other foods like kale and Brussels sprouts, mushrooms, and so on and so forth. No controversy. The area where there's some controversy is what is the quote best diet? And I would say that the best diet is the diet that is as close to minimizing those bad things that we talked about, maximizing those good things that we talked about, that you find enjoyable, you can eat with your friends and family, and is satiating and fun to do and will last a lifetime. I will make a case for you that a whole food plant-based diet, or moving towards a whole food plant-based diet, which is WFPB plus fish, is potentially an ideal diet that we should try to strive towards. And it's definitely not all or nothing. So there is some controversy. There are diet zealots who will say it is all or nothing, but I think the data shows that there's incremental improvements as you move towards better and better diets. There's some controversy as far as how much can a diet do, and this is different in different people. The effect size is very large if implemented early. And the effect size of dietary intervention, if done appropriately, is larger than any single medical intervention, even including the current Ozempics and Mounjaros of the world, because like the current weight loss drugs, diet affects many different pathways at once, reducing hypertension, diabetes, cholesterol, heart disease, but also cancer. And there's a lot of data for that, which these drugs have not been shown to do yet. And so I do think that if done correctly and effectively, which is very difficult to do, diet has a tremendous effect size. The mechanisms are still being worked out. Diet can reduce inflammation. Diet changes your microbiome. We're going to be talking about the microbiome. Diet is important for insulin sensitivity. And then there's a lot of controversy. People throw their hands up, and especially physicians throw their hands up. And there's a feeling out there that, well, let's not focus on diet so much because it doesn't work. People don't stick to it. It's not doable. And what I would say to that is that we just haven't figured out how to do it correctly yet on a mass scale. For those patients of mine, and there are hundreds of them now, who have figured it out over the years, and many of them have not figured it out after their first or second or third, but fourth attempt. But for those that have figured it out, it's not only life-changing for them, it's life-changing for their family, their children, their friends, their whole community starts to change as they change. And, I have two words, the Mars rover. We can put a rover on Mars. We can start to affect and be more mindful and deliberate about what we eat. Let's talk about different diets because there's a lot of information out there as to what kind of diets people should do. And people talk about ketogenic diets and Mediterranean diets. A ketogenic diet is a diet that has low enough carbohydrates where insulin secretion is inhibited. And when insulin secretion is inhibited, the body cannot use carbohydrates for energy, and the body needs to use other compounds for energy. So it starts to break down fat and go into ketosis. And it's a catabolic state. So to get into ketosis, which can be a very effective way to lose weight, one needs to cut out sugar and pretty much all simple carbs, very limited fruit intake, this leads to significant weight loss, but it's a diet that can be very difficult to maintain. It's a diet that, if done with high saturated fats, including meat and cheese and bacon and things like that, will lead to high cholesterol levels, higher LDL levels, and oftentimes much higher inflammatory markers, including HSCRP, which has been linked to future risk of heart disease. So I think for most Americans, a ketogenic diet is not a good idea for general health. A Mediterranean diet is probably the diet that we have the most large studies for. It is a diet that's high in fruits, grains, nuts, seeds, vegetables, fish, and extra virgin olive oil, as defined by the PREDIMED study, as well as a couple of other studies that were done before it. It is also a diet that's high in fiber and low in processed foods. There is some chicken, lamb, dairy, and eggs, but at small portions. So if you think about a meal plate, which is, the old plates that would show you, the part that's protein and so on and so forth. If you think about a meal plate, those things, those animal proteins, chicken, lamb, dairy, eggs, make up maybe 15 to 20% of the total meal plate caloric intake. So much, much lower amount of animal proteins, with fish being the one animal protein that has a large presence in a Mediterranean diet. And then a whole food plant-based diet plus fish, which I add to a whole food plant-based diet for lots of health reasons, which we'll talk about a bit more. So this is a graph that's from the PREDIMED study. The PREDIMED study was the largest study that looked at Mediterranean diets and mortality. That study showed that a Mediterranean diet is better than what was defined as a heart-healthy diet, as defined by the American Heart Association. So even better, that's not even compared to a regular diet, but compared to a heart-healthy diet, a Mediterranean diet led to less heart attack and stroke and mortality. These researchers took all of the data from that study and all of the patients that were randomized in that study, either in the control or the Mediterranean diet arm, and they had them take food diaries, actually what they were eating, because in the PREDIMED study, patients weren't given the food. They were just told how they should eat and given either olive oil or nuts, depending on what group they were in, or nothing if they were in the non-intervention arm. These folks went and did diaries on everyone, and then they put people into quintiles of adherence to a pro-vegetarian food pattern. Quintile 1 was the least pro-vegetarian, the least plant-based. Quintile 5 was the highest plant-based in the first month of the study. And then they followed them through the study over the next 5 years. And lo and behold, there's a dose response curve. The more plants you eat, the lower your mortality, which is quite interesting. This is a dose response curve is what we see with medications. The more medication you use, the better the effect. And so this food is medicine concept, is something that speaks to this slide. So how about let's take the two diets that we think are best and compare them side by side. And how do people do? So let's compare a Mediterranean diet with this study called it a low-fat vegan diet, but it's a whole food plant-based diet. There are other studies that I'm not going to show you because of time today that show that as long as your fat intake is healthy fats are not necessarily bad for you. And this low-fat concept is a holdover from sort of old type of thinking. But let's get back to this study. They randomized 62 people who were obese, had BMIs greater than 30, randomized to a Mediterranean diet versus a plant-based diet. And importantly, there was no calorie restriction. That's extraordinarily important because calorie restriction is a very difficult way to lose weight, especially if that's the only thing that you do. And I think calorie restricted diets, which is traditionally the way people would quote unquote diet, fail and have given dieting or changing how we eat a bad name. So this study did not calorie restrict. After 16 weeks, they crossed over, meaning the group that was on the Mediterranean diet then ate plant-based, and the group that was on the plant-based diet then ate Mediterranean. And what's interesting, the green line is at time 0 on the x-axis, week 0, both the group that was on the plant-based vegan diet and the group that was on the Mediterranean diet, they had similar weights, right? And as they went towards week 16, the plant-based diet lost significant amount of weight, and the Mediterranean diet lost a little bit of weight because it is a good diet. Then comes the crossover. So there's 4 weeks where there's washout. They don't adhere to any kind of diet. And then the Mediterranean group becomes the vegan group, now green. And lo and behold, over the next 16 weeks, they lose weight. The vegan group becomes the Mediterranean group, and over the next 16 weeks, they gain weight a little bit. And so this is one study that tries to compare apples and apples without calorie restriction. So what is special about a whole food plant-based diet plus fish? And I'm going to give you some general concepts which you can use to your own diets. The first is that it's called a whole foods plant-based diet. I don't refer to it as a vegan diet. I don't refer to it as a plant-based diet. And that's because the whole foods part is the most important part. If you leave this talk and leave and say, okay, I'm going to become vegan, I'm going to give up my chicken and eggs and have bread, pasta, PB&J sandwiches, which is a plant-based meal, you are completely missing the point. The most important thing is the whole foods part. So what's the difference between whole foods and processed foods? Processed foods have lots of additives. We know what each of these additives do maybe in our body. We have no idea what all of these additives together combined do. Many of these additives we're finding out have effects on our microbiome that we didn't know before. About a month ago, erythrotriol, which is something that's found in lots of NutraSweet sweeteners, which is a plant-based additive actually, was found to increase inflammation and heart disease. The other thing that's different about whole versus processed foods is the carb to fiber ratio, specifically of plant-based foods. So anytime you take a food or whenever you process something, in effect, oftentimes what you're doing is you're taking away fiber and you're adding carbohydrate. So your total carb to total fiber ratio, and I tell patients this may be one of the kernels that you should walk away today from. When you look at food, think about carbohydrate to fiber ratio when you're buying bread, pasta, because even though I'm a whole food plant-based plus fish aficionado is not a strong enough word. I still have bread and pasta now and then, especially as treats or when I'm out and so on and so forth. But when I'm buying this stuff and I can control, what I look at is the carbohydrate to fiber ratio. You look at the label, it says carbohydrate 21, fiber 3. That ratio is 7. You want carb to fiber ratios less than 7, ideally in the 4 to 5 range. Wonder Bread has a carb to fiber ratio of infinity because it's all carb, no fiber. White bread has a carb to fiber ratio around 20. Whole wheat bread has a carb to fiber ratio around 10. Ezekiel bread, Joseph's Lavash, Dave's Prisoner's bread, there's lots of other breads out there, have carb to fiber ratios as low as 4. So as you increase the amount of fiber per unit carb, you slow down the absorption of the carbohydrate. And then I'll talk a lot more about fiber in a minute. thing that we don't think about, even in the whole part of it, is that there's lots of chemicals and antibiotics that go into animal husbandry. So the animal products of today are very, very different than the animal products of 50, 100 years ago. And you can take a look at the picture of the chickens on the bottom. In 1957, the average chicken weighed less than a kilogram. The average chicken now weighs 4.2 kilograms when it's sacrificed. That doesn't magically happen. That happens because these chickens are being manipulated in certain ways to make them put on weight very, very rapidly. And that involves a lot of chemical intervention. The other thing that's important is nutrient extraction between whole versus processed foods. Patients often ask me, what kind of supplements should I take? And I say, unless you're deficient in certain vitamins, and oftentimes B12 and vitamin D may be the two that I focus on, don't take supplements, because supplements, every time they're investigated, show that they don't work. Even though we know that vitamin C is good for you, we know that giving vitamin C pills does absolutely nothing for health. And a great example of this is fiber. I told you before that there's zero controversy that the more fiber in your diet, the better for you. However, randomized, prospective, placebo-controlled trials that give fiber pills to patients versus placebo pills fail to show fiber does anything. That's because when you extract a food element, you're leaving behind hundreds, if not thousands, of chemicals, compounds that were found in the whole food that probably need to be juxtaposed in proximity to that element in your gut for them to be nutritionally active. You also, fiber is a good example. Fiber comes in hundreds, dozens, maybe hundreds of varieties between short chain, medium chain, long chain, soluble, insoluble. And so the diversity of these nutrients in whole foods is very, very different than a chemically made structure or an extracted structure. So that is very important. Now, why plants versus animal? The most important thing that I want you to leave away with is the fiber concept. Animal proteins are protein and fat. Eggs are protein and cholesterol. Egg whites are protein only. Plant proteins are protein and fiber. Certain plant proteins have poly and monounsaturated fats. When you move from animal protein to plant protein, you're creating caloric space in your diet to eat more fiber. Fiber then is the prebiotic, the food for your gut microbiome. Fiber has very low caloric density, takes up space, fills you up, easier to lose weight. Fiber is very important for gut motility. The gut moves food down the intestines through a peristaltic motion, and fiber is what stimulates that peristaltic motion. The more fiber you have, the faster everything goes through the gut. We have very long guts compared to our body surface area, as do other animals that eat lots of plants like chimpanzees and cows, as opposed to animals that have very short gut length compared to their body surface area, like cats, for example, carnivores. When you have a long gut, if food is moving slowly through the gut, the food will spoil, just like it spoils on your kitchen countertop, specifically when it's an animal protein, because the bacteria that grow on animal proteins are different and harmful compared to the bacteria and yeast that grow on plant proteins. And when you hear about E. coli on lettuce, it's not because E. coli eat lettuce, it's because the watering system of the lettuce, the irrigation system of the lettuce was downstream from an animal husbandry farm where E. coli was in the animal products and the stool and so on and so forth. So So those are some important things about fiber. There are many other differences, but in the interest of time, I want to keep going, and I can always answer some questions afterwards. So why is fiber important? This is just showing that it is important. These researchers took every study that pre-specified had fiber as something that they were going to look at, and mortality and from heart disease. And they put all of these studies together, and there are dozens of these studies. And on the bottom x-axis, you see the amount of fiber per day. And on the y-axis, it's the odds ratio of having a heart attack. Most Americans have about 10 to 15 grams of fiber, which is the red arrow, in their diet a day. And their odds of having heart disease is higher than an odds ratio of 1, meaning they're 1.5 times or 1.2 times, 20% more likely of having a heart attack or stroke. The Mediterranean diet is the blue, has about a fiber amount of about 25 to 30 grams a day, and they have a lower incidence of having heart disease. A whole food plant-based diet plus fish 3 times a week, so all the other meals being whole food plant-based, has upwards of 60 to 70 grams of fiber a day, which is off the chart here. And that's the end of the talk. This is the last slide that shows what happens when you eat a plant-based food to LDL cholesterol, which plummets, and what happens to C-reactive protein, which is a marker of inflammation, which plummets. And this study compares it to a statin, which is the strongest medication that we have to lower LDL cholesterol, or used to be the strongest medication that we have. So again, this concept of food as medicine, here you have food doing the same thing that a statin does, not just to LDL cholesterol, but also for inflammation. The line that doesn't change is the placebo line, the control line.
Thank you so much for that, Dr. Yagub. Today, I learned so much. You're clearly so passionate about this. I wanted to mention during your introduction, and I failed to, and I'm sorry, but you have been featured on the Today Show as an expert on, dietary practices, a whole foods plant-based diet plus fish. I think I learned so much. I do want to mention something that I should have talked about, which I'm very passionate about, is like anti-soda. So my 5-year-old and my 8-year-old hate when daddy drinks Diet Coke with like Mexican food. And he's like, it's just with the Mexican food or the pizza or whatever. But sugary beverages are one of our biggest enemies. So I think that that's a really important point that you brought up that I failed to bring up. You talked a lot about hemoglobin A1C and what that means. So this is a diet about, talk about diet and weight loss and all of that. But because there's such a strong link between being overweight and obese to diabetes, I just want to explain it for a couple of the people who may not know what their hemoglobin A1C should be. So hemoglobin A1C above 5.7 is considered pre-diabetes, which means that there's a strong chance of developing diabetes in the future. And a hemoglobin A1C above 6.5 is considered having diabetes. Once you have diabetes, it's it doesn't matter about just the sugar control. It's sort of a systemic problem, and it can affect cardiovascular risk independent of how well your sugar is controlled. So the whole goal of all of this is to show that, eating a healthy diet, losing weight, doing it in a positive way can actually prevent development of diabetes and then also future cardiovascular risk. So I think that's great. Thank you. I know that you're so into the diet that you stand for and that you're an expert on, but you did mention all of the others. There's been a lot of press about the keto diet and future cardiovascular events. As a cardiologist, can you just talk about why the keto diet is not something as cardiologists we would recommend?
Yes, absolutely. So again, it depends on exactly how you're doing a keto diet. There are ways to minimize carbohydrates to the point that you go into ketosis without having a high saturated fat diet. So you can have lots of fish, nuts, seeds, a bunch of greens and vegetables and mushrooms and things like that. some chicken, eggs, and the thinking is that it's the saturated fat in a keto diet that is problematic. And that for sure, there's no controversy about and everybody agrees on, and increases inflammation as well as increases LDL cholesterol, which then will increase atherosclerosis and plaque buildup. But there are lots of research studies now that are also showing that although proteins are essential and very, very important to have in our diets, an overabundance of protein is a stressful part of the diet on our kidneys, as well as includes an acid load. One thing that I didn't talk about is that the amino acid differences between animal proteins and plant proteins. Animal proteins have sulfate groups in their amino acids, so they're acidifying when they get changed to hydrosulfuric acid. And acidifying foods are bad for osteoporosis, because one of the ways that we stabilize our blood pH is by taking calcium phosphate out of bone. And so there's lots of the parts of the keto diet that are concerning, especially when done over a long period of time. For a very quick, I want to lose a lot of weight in a couple of months, the keto diet is the most effective way to do that scientifically.
My brother and his fiance did the keto diet for 2 months prior to their wedding, and both of them looked like different people on their wedding day. So I can understand that, but I told them the same thing, that in terms of like continuing that in the future, and yeah, just future cardiovascular events are increased with a prolonged keto diet. Do patients ask you a lot about the benefits of intermittent fasting? Because the mechanism is similar, right?
Absolutely. Well, what I tell patients, first of all, is what you're really asking me is about time-restricted eating, because intermittent fasting would be a true fast, meaning a water-only fast for greater than 36 hours. And so you really need to either do a fasting mimicking diet where, again, you're having either minimal calories or minimal carbohydrates of any kind, to be able to become ketotic. And so most folks talk about time-restricted eating, which is finishing at 8 p.m., for example, dinner, and not eating again until 8 o'clock in the morning, 10 o'clock in the morning, and then ideally around noontime. So you're doing a 16-hour fast and then 8 hours of eating. And it is a very, very effective tool, and I've found that in many of my patients. I think the mechanisms are still to be figured out. I don't think it's so much from ketosis, actually, specifically in time-restricted eating. I think the main benefit is, and I did it myself, whenever I recommend something for a patient, I'm like, I got to try it myself for a while and see, does it work? Does it not work? What happens to my numbers? And so on and so forth. The main benefit is that you're hungry in the morning. I used to be somebody who I snack, and it's because I had to constantly satiate my hunger. When I did it for a month, and because it was a thing that I was doing, it was a game, I said, committed to do this for a month. I learned to live with hunger. I learned to be okay being hungry. I learned to control how I felt when I was hungry, because I had to work, I had to take care of patients, not yell at my kids, and so on and so forth. So after I did that for a month, all of a sudden, I wasn't like ravaging for food, scavenging for food all the time. So it was a mental thing.
Yeah, that's what a lot of patients of mine have said as well, that when they want to lose weight, they've tried intermittent fasting very successfully, especially if they're people who weren't eating breakfast to begin with.
Right.
And so I think that that's something that, is there any population that you would say, particularly elderly or anything like that, where you would advise against time-restricted eating?
Yeah, so a couple of things. First of all, it's very, very clear that being overweight when you're young, especially, and into middle age, is extraordinarily problematic for all kinds of diseases. Once you reach the age of 75, if you said, Houman, would you rather be 10 pounds overweight or 10 pounds underweight at the age of 80? I would say 10 pounds overweight. Now, it's obviously best to be healthy, muscular, active, exercising and eating healthy. But as you get older, being low weight is more and more and more dangerous for lots of reasons. And we can talk about that some other time. But so along those lines, I think it's a bit problematic if you're trying to lose weight when you're already at a normal weight. And then also when patients are taking medications, when you're doing time restricted eating, you're having wide swings of blood pressure, hydration level, hormone levels, and so on and so forth. And so you have to be a little bit careful. And I would recommend that patients talk to their physicians about that.
Absolutely. I think that that's 100% accurate. And then the last thing I wanted to ask you, which is something that you really drove home, and I think that we don't talk about this enough, is the importance of fiber, natural fiber. So a lot of people, family members included, taking like over-the-counter fiber supplements, Metamucil in your water, that kind of thing. What is the benefit of that? What is the benefit of the supplement versus natural fiber, and then what kinds of foods are high in natural fiber that we should be sort of.
And I bring people back to that whole supplement extracted foods in placebo-controlled trials, including fiber, not showing benefit. And so I tell people to try to get their fiber from natural foods. And one easy way to do that is to take flax seeds, pulverize, crush them, or buy flax powder. And I have patients put a tablespoon of flax powder on their breakfast, lunch, and dinner. Flax powder is almost tasteless, has a little nutty flavor to it, and it pretty much goes well with anything. And so flax is a great thing. I will add chia seeds, for example, to my shake in the morning to even boost the fiber more. But especially if you're sticking to a plant-based diet, you don't need to add fiber. There is way more fiber than you can ever imagine in a plant-based diet. So if you're doing a plant-based diet, forget about it. You don't need any supplemental fiber at all. If you're not, trying to bring in fiber-rich foods that have other, for example, flax seeds have omega-3 fatty acids, and if you eat nuts, they're going to have poly and monounsaturated fats. And if you have whole grains, they're going to have B vitamins and a whole bunch of other things that come with natural foods.
Well, thank you so much. This has been so beneficial, so useful, like so much information packed in there. And it's not a topic that we talk about often enough from an expert. It's oftentimes like a nutritionist or somebody like that that's just giving, practical tips, but you really dove into the research and everything too. And I so appreciate you joining us. And for everybody who's been watching today and getting all of this information, just know that even though this seminar was talking about the risks of being overweight and obese, you are all absolutely beautiful just the way you are. We're trying to just give you information that will help in terms of future cardiovascular risk and things that people should know so that you can feel empowered when you walk into your doctor's office and make the right decisions. So hopefully this was useful and beneficial to all of you. I can't wait until our next seminar, TBD, what that will be. And I want to thank both Dr. Kumar and Dr. Yagupzadeh for their time today. Thank you so much.
Thank you. Thank you.